A warm welcome, everyone, to the second day of our conference on how can we dismantle health inequity together, National Voices Conference to realise the power of the voluntary sector. It is our pleasure to have you all with us today. I'm Rebecca Steinfeld, Head of Policy at National Voices, and I'll be facilitating this morning's discussion. Today we will be talking about race and health. But before I get into the issues, I want to make sure all of you are able to join our conversation in a way that works for you. So let me just talk you through the tech. Laura, if you could just change to the tech slide, please. That would be great. So we've tried to make this conversation, thank you, as inclusive, accessible and interactive as possible. We welcome you all to display your pronouns in your Zoom name as I've done. We also have a palantypist who is capturing speech and putting it into writing. If you click on CC live transcript at the bottom right, you can enable captions. We're going to have the palantypist with us here today until 10:15, but unfortunately, due to the illness of the original palantypist who was scheduled to be with us, the replacement had a prior commitment, will have to leave then. And so then the captions will go into auto captions and there'll be a slight decrease in the accuracy of them. But you don't, as an attendee, have to click anything. It will just automatically switch for you. For those with the BSL interpreter, we're pinning and spotlighting them for you. We've also enabled a chat box, which you can click on in the center of your screen. Please introduce yourselves there. Tell us what brings you here today. And as you listen to the discussion, feel free to share your reflections there. We're also going to paste a collaboration document, a live Word document into the chat, and you can share your contact details there if you would like, so that you can be contacted and so that you can contact others, so you can carry on the conversation and plan joint action. We've also got a Q&A box, again, in the middle of your screen at the bottom. If you have a question that you would like to put to a speaker, please put it in there and we will try to make sure it's answered. And finally, we're going to be using something called Mentimeter to ask you to respond to a couple of questions about race and health. And I'll then share responses. There'll be 2 word clouds. Just to say that there is no obligation to use all of this, and we know it can be overwhelming, but we wanted to make sure that there were lots of different ways for people to get involved in the conversation, and you feel free to tune in as you like. So now that the tech is covered, on to the substance of today. This morning we will be discussing race and health inequity. Racial inequity in health long predates COVID. To give you one glaring example, Black women were 5 times more likely to die in the perinatal period than white women, even before COVID struck. And here's a post-COVID statistic for you. Black women are 4.3 times more likely to die of COVID-19 than white men and women. Clearly, though we have all been in the same storm, we have not been in the same boat. But at the same time as the dire nature of this racial inequity has become so much starker, the energy to come together to tackle racism has renewed, most prominently through the Black Lives Matter movement. In health, it seems there are 2 problems. First, gaps in income, jobs, housing, education, and so on generate gaps in people's levels of health and well-being. And second, some people face additional barriers to access to healthcare or are treated differently when they come for care. Together, these create racial health inequities. But what does this really mean for people, and how can we tackle all of this together? Today, we will platform those who have led campaigns and mobilized people to combat racial inequality in health. We will discuss how we as a sector can support positive, sustainable change that is led by and works with affected communities. To help us identify what each of us can do to tackle racism in health, we're joined by 3 excellent speakers. Sanisha Wynter, an expert by experience, mental health advocate and inclusion specialist. Dr Halima Begum, CEO of the Runnymede Trust and board member of the NHS Race and Health Observatory. And Dr Habib Naqvi, director of the NHS Race and Health Observatory. Before I hand over to them, I just want to make 2 brief points. One on language and the other on the voluntary sector. We know language around race is contentious and with good reason. What works for some jars with others. But we don't want to get stuck into that debate now, important though it is, and miss out on a fuller discussion about health and race. So the speakers will use a range of terms that work for them: Black, Brown, BAME, BME, people of colour, communities of colour, racialised communities, and I will try where possible to follow speakers' leads. The second, I want to acknowledge an elephant in the room. We know there is a problem of an absence of colour in the voluntary sector, as highlighted so well by Charities So White. And we at National Voices are working to address this in our own organisation and throughout this conference. We're committed to better representation and to making sure we speak with and not for people. We don't assume a natural right to lead in this space, but we are also convinced that it is not good enough for us to just sit back. So on that note, and without further ado, it is my pleasure to introduce you to our first speaker, Sanisha Wynter. Sanisha identifies as a Black bi cis woman who lives and thrives with borderline personality disorder and depression. She is a diversity and inclusion consultant, has worked in various roles in the charity sector, and in 2019 was listed as a bi icon of the UK LGBT charity Stonewall. We asked Sanisha to reflect on the question, what racial injustice and health inequity mean to me? Thank you for joining us, Sanisha, and over to you.
Thank you very much for that introduction, Rebecca. From my experiences, racial injustice and health inequity means a disparity in access to services, treatment and support. These issues are not easily dismantled, and it can be challenging to address and provide solutions because talking about racial injustice and health inequity can be dismissed. Biases can overshadow the conversation, and lived experiences are not always centered. There are several instances in my personal experience which have highlighted the impact of racial injustice and health inequity. My mental health journey in getting support continues to be complicated. I remember initially asking for help during a depressive episode and being told by a doctor, "You are a strong Black woman. Why don't you try praying more?" Strong woman narrative placed on Black women can kill because this experience only further exacerbated my depressive symptoms. I didn't feel like my pain was believed or seen. In 2017, I was diagnosed with borderline personality disorder and mixed anxiety and depressive disorder. When I received psychotherapy, my therapist let me know at the start she had never worked with a Black or bisexual woman before, and she didn't understand the issues and she would need a detailed explanation about my Black experience. However, I did feel my trauma took a backseat to facilitating her understanding, and she kept praising how strong I was. And again, I felt dismissed because at this time, I did not feel strong at all. Research suggests that experiencing racism can be very stressful and negatively affect overall health and mental health. Having to explain my issues and trauma to a white woman, particularly about racism, was triggering. Talking about race within the UK, the narrative can feel you are oppressing yourself, you have a chip on your shoulder, you're bringing race into the conversation, you're making accusations instead of merely speaking your truth. I was cautious about managing her feelings over mine, and this negatively impacted my treatment. And health equity isn't limited to personal experiences and community mental health services, but also in the workplace. On joining a new organization, I had an occupational health assessment, and the assessor informed me he was a doctor and was familiar with BPD patients. The doctor told me, for a woman with a severe mental health problem, I sound so normal. The doctor didn't expect me to be so articulate, and he told me women with BPD are often manipulative. I was shocked and frustrated. I made a complaint and I was told he didn't mean it to be an insult. It was a compliment. And because I have BPD, it's not my fault I'm hypersensitive. Dismissed again. And it's not just me. I see how other Black people face health inequity. My family members also have severe mental health problems, from schizophrenia, psychosis to bipolar. Statistics tell us the risk of psychosis in Black Caribbean groups is estimated to be nearly 7 times higher than in the white population. and my family is heavily impacted. However, the conversations around seeking help and taking medication are negative. My family had warned me that if I sought help, I would be locked up. In some communities, mental health problems are rarely spoken about and can be seen in a negative light. This discourages people within the community from talking about their mental health and could be a critical barrier to engagement with health services. My family, like me, struggled to engage with mental health services in general. We received limited to no support only at crisis point, and then the only solution is to be involuntarily detained. Black people are more than 4 times as likely as white people to be detained under the Mental Health Act. This statistic only exacerbates the culture of fear and stigma of sharing your mental health problems. So with that reflection, I ask, why are health services further impacting racial injustice? We know the impact of the higher rates of mental illness is that people from Black Caribbean and Black African groups are more likely than average to encounter mental health services. So why are health services not doing more to support this community and tailor the service around their experiences? This question is a crucial reason why I was so keen to speak at this conference and share my experiences. I am fearful of becoming pregnant. As Rebecca said, Black women are 5 times more likely to die in pregnancy, childbirth, or in the postpartum period compared to their white counterparts. And I asked why? Why does this happen? What is the justification of this statistic, if not racial injustice? I'm reminded of finding my own mother hemorrhaging after giving birth to my younger brother, being discharged before she was ready. She was told she was strong and looked like she had color in her cheeks, although she couldn't stand and had shared she was in pain. The negative experiences of pre and postnatal care are shared continuously by Black women around me, and this continues to feed into this culture of distrust and fear. And these experiences are not unique to my family, but many Black families, and they shape our engagement and trust within health services. With all disparities, how can we sit by knowing for years the statistics, even more recently, the disproportionate impact COVID has had on BAME communities? Personally, I feel a sense of responsibility to address the issues of mental health support for Black communities, and I share my lived experience to educate others in the barriers to engaging with health services and propose solutions on what could have helped me. Last year, I took part in a research study by King's College London about people's experiences and their views of how community services support people with complex emotional needs. Other marginalized people must be informed of these studies to ensure we have representation in the findings, to ensure our voices are heard, our experiences are recognized, and something is done about the issues of access and engagement. I've also worked closely with junior doctors at King's College Hospital in London as part of Psyched Up, an initiative supporting medical students to understand mental health illnesses by working with experts by lived experience. To role play how to communicate with someone in crisis, someone seeking support, someone needing help. Role playing with the students and how their body language, their verbal responses can be seen as dismissive or offensive. The experts, by experience, reminded the students that their role is not to assume, but to help, to recognize their biases, to know when to escalate for safety, and remind them that for some Black people, discussing mental health and being vulnerable is a tremendous and potentially frightening experience. After the study, the students felt they had a better understanding of cultural intelligence and had practical methods for engaging a diverse range of patients. The changes I would like to see is for the disparity in statistics to improve drastically. I would like to see more therapists of color from diverse backgrounds being employed and for training programs to center experts by lived experience. I want the stigmas on borderline personality disorder by health professionals to be removed, and I want a person-centered approach. Due to the culture of distrust, fear, and the statistics that frighten us, there will continue to be several challenges in engaging with diverse communities. However, these challenges must not negate the responsibility we have to reduce health inequity. We must be intentional with inclusion from the outset and throughout an individual's healthcare experience. This conference is an excellent opportunity to address the issues we all know, to collaborate, to understand the intersections of culture, beliefs, and stigma. There is a circular relationship. Health inequity can be impacted by racial injustice and vice versa. These are not standalone issues and must be addressed. Thank you.
Thank you so much for that, Sanisha. I can see what you've said has really resonated with a lot of people from comments in the chat. And I'm looking forward to hearing more from you when we get to the Q&A bit. Before I hand over to our next speaker, we have an interactive activity that we're launching in the chat. My colleague Laura has just shared a link to Mentimeter. If you click on that, you'll see there's a question we would like you to reflect on. And that is, what comes to your mind, when you think about racial inequalities and health? We'd like 1 or 2 word answers, please, because this Mentimeter will generate a word cloud. And you're able to carry on doing that whilst the next speaker starts speaking. So just to say, what comes to mind when you think about racial inequalities in health? And I'll share the results of what you've said after Dr. Habib Naqvi has spoken. So now it is my pleasure to introduce Dr. Habib Naqvi, Director for the NHS Race and Health Observatory, which is supported by NHS England and hosted by the NHS Confederation, and has been established to identify and tackle the specific health challenges facing people from Black and minority ethnic backgrounds. Habib worked in public health for 10 years. He's worked at NHS England, where he led on national equality and diversity policy and strategy for the NHS. And perhaps most interestingly, certainly from my point of view, Habib also reverse mentors the chief executive of the NHS, Sir Simon Stevens. We asked Habib to talk about why we need to combat racism to improve health, and how the NHS and VCSE sector can work together to do so. Thank you for joining us, Habib. Over to you.
Great. Thank you so much, Rebecca, and thank you so much as well for your powerful talk, Sanisha. It was wonderful to hear the important critical messages you have, because I think this conference and these events are absolutely essential for us to have a clear focus on looking at meaningful and sustained change, because we know that when we look at race and health, that there are ethnic differences in terms of access and experience and outcomes in a range of different areas, whether that's genetic counselling or artificial intelligence or maternal health, which we've talked about as well, which I'll go into a bit more depth just to give an example of that. But those disparities are set against the higher prevalence of conditions that we are all too familiar with: specific cancers amongst the Black and Asian communities, higher rates of diabetes and cardiovascular disease, mental illness, and of course, what we've seen over the last 12 to 13 months now is the disproportionate impact of a pandemic, COVID-19, on our Black and minority ethnic communities, which has shone yet another light on the ethnic disparities and the stratification in outcomes that we see within our society. So there is a level of urgency to focus on this area, but to focus on this area in a sustained and meaningful way. We have, or I guess we are well placed to do exactly that in terms of our country, in terms of our healthcare institution, because we've had a long history of migration in this country, which goes back not just decades, but centuries. We've therefore got large and growing Black and minority ethnic communities. We've got robust legal frameworks in the Equality Act and the Health Inequalities duties. And we've always had very good investment in healthcare research, and the Oxford vaccine is just one example of that. But I guess at the same time, it can also be argued that focus on in these areas over time have been somewhat fragmented, a little bit confused, and somewhat costly as well. And whereas think tanks and institutions and commissions have been set up to focus on ethnic disparities in health, they have largely, in general, focused upon theoretical recommendations and data collection exercises with little focus on the actual practical implementation on the ground. So the NHS Race and Health Observatory has been set up. We're kind of 5 months into the observatory's time at the moment. It has been set up to look at transforming the disproportionate impacts that we see upon our Black and minority ethnic communities with regards to health. We will be focusing on looking at what I call the causes of the causes. So not just the surface level issues. COVID is a typical example. Now, we've had numerous reports from various national organizations and even the government around what is causing the disproportionate impact amongst Black and minority ethnic communities with regards to COVID-19, and various factors or contributing factors have been highlighted, including the fact that BME communities are more likely to work on the front line, more likely to be in poorer housing or multi-occupational, multi-household residents. But I guess the question is, why is it that they're more likely to be working on the front line? Why is it that they're more likely to be living in multi-generational households, or more likely to have comorbidities? So looking at the causes of the causes is absolutely essential for us to have sustained and meaningful outcomes with regards to this agenda. So the observatory, yes, it will be observing, but it will also be speaking, and it will be acting as well to make sure that we can actually focus on what we need to focus on. And it has kind of 3 pillars to it. Firstly, the intelligence, the rapid reviews, the research, the insight and engagement that we need, including, of course, with our community and voluntary sector. Secondly, turning that into actionable recommendations for change on the ground. And thirdly, supporting the healthcare system and other bodies to implement those recommendations. And that's the 3 pillars that we are focusing on in terms of anything that we look at, whether that's maternal health, whether that's COVID, whether that's diabetes, or whichever area that you want to focus on. And we've established a phenomenal, I say, powerful board within, I think is one of the strongest and most powerful boards within healthcare. And one of the reasons for that is because of the diversity of the board and the diversity in its representation and diversity of thought. And it's a pleasure to have Dr. Halima Begum, who will be speaking in a minute, who is a board member of the observatory, and that's absolutely fantastic as well. We have also established a stakeholder engagement group as well, which is, I guess, the eyes and the ears for the observatory on the ground. And we will be engaging with not just National Voices, but other national organizations and local organizations in order to make sure that what we work on is absolutely grounded and will make a difference. We are independent from the NHS in that we are supported by NHS England and hosted by NHS Confederation, but we are at arm's length. And that level of independence is really important because people need to be confident in the objectivity of the research and the recommendations and the support that we provide. And it should no longer be the case that national organizations set their own exam questions and mark their own exam papers on this agenda. We need a level of accountability, and we need to hold up a mirror to not just organizations, but to individual leaders as to what action, how are they taking on the race inequality agenda. Maternal health has been highlighted before, and it is one of the areas that we have started focusing on within the Observatory. Just as colleagues have said already, the unacceptable statistic that Black women are up to 5 times more likely to die during pregnancy, childbirth, or soon after, Asian women being up to 2 times more likely to die during that period, is something that you know, within the 21st century, in a so-called progressive society, is something that should not be there. It should not be a statistic that we should be reading out during conferences and kind of scratching our heads around. We need to focus on that, and to focus on those issues, we need to be looking at, as I said before, the causes of the causes with regards to this. And we need to be looking at racial bias. We need to be looking at racial bias in clinicians' assumptions around things such as pain management amongst different communities, racial bias in terms of policies and processes that have been in place, not just for years, but for decades, not just in the NHS, but within society as a whole, and racial bias in terms of the evidence upon which healthcare interventions and healthcare services are designed and commissioned and delivered to our diverse communities. And we need to focus on transforming those particular issues. We also have to listen, and my excellent colleague Bren from Gloucester, who's on this call, on the chat as well, he's part of our stakeholder engagement group, a fantastic leader at local level, doing fantastic work, which is having ripple effects at national level as well, has reminded me this morning in a text that we have to listen to the quiet voices and to amplify these. And Bren is absolutely right in that. We need to listen to those voices, but not just our BME voices, because for decades now, we've expected BME people to stand up and talk about their lived experience, which is great. But what we haven't done is to turn that around 360 degrees. And Rebecca mentioned reverse mentoring Simon Stevens, which is, it's a fantastic experience, but it's also about acknowledging and listening to other voices as well, including those voices that have privilege in our society, and what it means to have privilege, not just within our healthcare sector, but within society as a whole, and what impacts that has upon people's life experiences, chances, access to services, but also experiences and outcomes of services as well. I'll just finish.
Habib, okay, go on, just because we do need to move on.
I'll just finish with the line that we all need to work together in order to close down the aspirations of our ideals, which is around equity and inclusion, and the reality of the time that we live in. And that reality does include Black Lives Matter. That reality does include the 5 times more likely to die statistic in pregnancy. And that reality does include the disproportionate impact of COVID-19. So working together, and through the Observatory, we'll be doing exactly that with national voices and other organizations to have sustainable and meaningful change.
Thank you, Habib. Thank you for those insights and for those commitments as well. There's a lot in what you've said to unpack, I think, in relation to maternal mental health, something that we're going to be discussing actually in quite a lot of detail this afternoon in the second of our sessions at 2:15. The charity Birthrights, who are members of National Voices, will be joining us to talk about the inquiry they have launched into why there is still this outrageous disparity in maternal mortality between Black and white women. So do join us then for that. Before I hand over to Dr. Halima Begum, I would like to share the word cloud results from the first question that we put to you, which was, what comes to mind when you think about racial inequalities in health? So the words in the middle of this egg-shaped thing show what most of you said, the words that were frequently occurring. So you can see injustice, bias, racism, discrimination, ignored, pain, access, anger, stigma. So a lot of really powerful things that need to be confronted there. And and also some ways to confront them. And I saw this coming up frequently in the chat about action, and about tools that we can use as well, human rights, for example. And we will definitely come onto that in the Q&A about what specific actions people here can take. Before we get to that though, I'd like to launch the second of our interactive activities, which asks you to think about some of the barriers that we might face when we try to take action. And those might be sort of internal barriers that need to be overcome. They might be external ones. They might be things you've encountered or things that you think you would encounter. The question is, and there'll be a link again in the chat in a moment, but thank you, Laura. The question is, what are the barriers preventing voluntary sector organisations from effectively tackling racial health inequalities? So I'll say that again. What are the barriers preventing voluntary sector organisations from effectively tackling racial health inequalities? And again, if you could use 1 or 2 word answers, that would be fantastic. And feel free to carry on doing that whilst I introduce our next speaker, who is Dr. Halima Begum. Halima is Chief Executive of the Runnymede Trust, which is an independent race equality think tank working across a number of different areas. Halima has held senior leadership positions across policy, programmes and research with a range of organisations, including the Foreign, Commonwealth and Development Office and the British Council. As a disabled Muslim woman raised in London, Halima is a lifelong campaigner for equality and civil rights and co-founded the organisation Women Against Racism. We asked Halima to answer the question of how can we combat racism in health. Thanks for joining us, Halima, and over to you.
Thanks so much, Rebecca, and it's just an absolute pleasure to speak on this issue, and particularly after hearing such compelling accounts from Sanisha and also the institutional accounts from Habib. So what I will say that it's becoming a lot easier to talk about the very difficult stuff that we never used to be able to talk about before. So the very fact that we've got Habib and Sanisha like putting those difficult concepts on the table, to me feels quite reassuring that we've got some of the issues, the right issues on the table. So that's really great. So thank you for allowing us to come and share our thoughts on this incredibly important topic. Before I go on, I would like to say my colleagues don't let me out the office unless I tell you to follow us on social media. So could you follow me on Halima_Begum? That's just housekeeping. Thank you. So look, one of the difficulties of going at the end is that you don't want to cover ground that others have covered. But there is one statistic that, and I would like to just focus back on, that I think Sanisha, Habib, and actually, Rebecca, you've also surfaced quite early on, and that is definitely the one around maternal mortality. And the reason why I raise that is because it's unacceptable, as Habib said, in the 21st century, in a mature democracy with a mature health system that's publicly freely available, that such a thing should happen. So it is a shocking killer statistic. But the other stat that I wanted to come back to was one around the NHS staff who died during COVID. Yes, COVID is obviously a temporary crisis, which hopefully we will recover from, but it does show very structural issues underlying the health system. And the one I wanted to talk about was the fact that 60 of the first 100 NHS clinical staff to die of the disease itself were BME, despite the fact that only 20% of NHS staff overall are from a BME background. Now, I quote these stats back at me and ourselves because, not because I want us to be paralyzed with that statistic and not be able to do anything about it, but to help us understand why that is so. It isn't because an individual doctor went out there and decided to put himself or herself at risk. No, that wasn't the reason. It's because of the structural racism within the workforce, right? That's why they were disproportionately exposed, disproportionately affected, and so on. It wasn't because individual managers decided to be racist on that day. It wasn't because of that. And it's really important that we understand the institutional and the structural reasons for these failures, because otherwise we will never shift that needle. Otherwise, we'll be listening to individual accounts of people who have suffered, who didn't get the best treatment, and we'll be here 40 years down the line. So that's That's my message to you, that when we want to think about making that change, what is that change about? Is it the incremental change, or is it a systemic change, or is it something in between? And obviously you can't achieve one change without the other, but if we simply talked about the individual changes that we each want to make, I don't think we will get to the results that we want to do. Why does that all matter? I noticed that some of us are discussing health equity and inequity as opposed to inequalities. This is quite a fundamental point, because in this country, at least for the last 50 years, we've had an equality of opportunity, right? We've had an equality of access. We've got the best NHS publicly funded health service I can think of. And I'm speaking from experience. I have worked in China, I have worked in Indonesia, I've worked in Pakistan, I've worked in Denmark. We have one of the best public institutions to be proud of in the health area. But despite that, somehow the health inequities exist. And the reason why they exist is because the systems piece isn't working. It just isn't working. I'd like us to talk about the equality of results and the equality of outcomes. And Habib, as you rightly say, what is stratifying those outcomes? Because if we start with that, we might actually be able to work backwards. If we only looked at equality of opportunities, we'll just sit there very passively and say, oh, but you know, health is free at the point of delivery. And you know what, the vaccine is available for everybody. So why are these BME groups not taking it up? Oh, they're so unsure about it, it must all be their fault. Do you see what I mean? So if we don't talk about the outcomes and the results, I think we're pushing blame and responsibility on patients that are seeking treatment who might have different needs and so on. So it's about reframing the way in which we talk about health inequities. I also wanted to help us understand the analogy by looking at climate change, right? Just take away the emotion of it a little bit from racism, because racism is very emotive, as we know. When we discuss climate change, we do not say, can each individual keep on using recyclable carrier bags? Yes, it helps. It's good to nudge that behavior. It's good to get people to change. It's good to get people to talk about climate change. But fundamentally, the way in which we're going to save that planet isn't because of individual actions that I can take in my local authority. It has to connect up to a bigger systems piece. It has to connect up to companies that are still producing plastics at a cheaper rate, so that the consumer goes to buy something cheaper rather than something that's healthier, for example. So we need to think about that bigger piece. And that's why I keep coming back to the systems piece. Sanisha, I heard a lot there in your lived experience. That was also about gender. It was also about other identities. It was about our intersectionality. When we come in through the health service, we don't just come in as a cardboard cutout of a person that needs to be understood as one gender or one identity. We come in with various needs. We don't go in as stronger people. We actually go in to seek help. So there's a lot there within the health service that doesn't really understand our intersectionality. And why is that? And what can be done about that? I think there is more that the government can do, actually. So at the moment, there's a lot of focus on the NHS, but the NHS doesn't exist in a vacuum separate of the government support and regulation that exists for public health service in this country. So there's a lot on the government to do, I believe, and they still haven't done enough. Now, one of the things that the government doesn't do at the moment is, they collect data on other racially protected characteristics, like race, for example. But the one thing it doesn't do is collect data on. You could go in as a middle-class Black person, middle-class Bangladeshi person. You might even be able to advocate for the right service for yourself. But if you are a working-class Black person or a working-class Bangladeshi, like my father, for example, you cannot go in and be treated in the same way. And it's really important that we actually collect data on race and class and gender together, which would then allow health professionals to better understand what those needs are. And that doesn't happen. Now, for some reason, this government is unable to put forward a piece of legislation that is currently on the statute book around actually protecting class. I mean, it's literally there, it's sat there for 10 years. And this is known as a socioeconomic duty of the current Equalities Act, that is our equalities legislation. Just doesn't do it. If we were to do that, we might actually make more progress. And finally, I just wanted to get back to a point around 1 minute firefighting, right? One of the key impacts of structural racism for us is that there's that continuous sense of racial justice and injustice, because we're firefighting. There's Grenfell, there's Windrush, there's COVID, there's this, there's that. And to really get at the causes of the causes, you actually need a bit of time. You actually need a dedicated effort to unpack what those solutions might be. But because there's a new crisis every year, we're now unable, I think, to get to that systems piece. So, you know, if our decision makers were to think about it in sequential terms, like there's what we're reacting to, but there's the systemic piece that we need to look at, we might make the joint progress that we seek to make. And I'll stop on that point.
Oh, thank you so much, Halima. That was absolutely fascinating. And I think, yeah, touches on a sort of recurring theme, I think, that I can see coming up in the chat of how to sort of balance dealing with these deep structural issues and really getting to grips with them and understanding them on a granular level on the one hand, and then sort of taking action to, you know, address things in the here and now, how difficult it is. And hopefully we can talk about that some more in the Q&A. So I just wanted to share with you the results of this second interactive activity, where I asked you, what are the barriers preventing voluntary sector organisations from effectively tackling racial health inequalities? Funding, big blue letters in the middle there, ignorance and resources connected to funding, knowledge, representation, racism, lack of diversity, systemic racism. So the problem itself prevents one from tackling the problem, as well as the practical things needed to tackle the problem. Okay, that's really interesting. Thank you all for sharing that. And we'll be sharing these word clouds with you after the event, together with the YouTube recording, so that you can look more closely at those results. We now have just under 50 minutes, I would say, for a Q&A. And I've seen some really interesting questions coming through, and I have some that we also have discussed in advance. And I just wanted to first sort of put some of those to the speakers here. So, Sanisha, you talked about stereotypes, how stereotypes, and in your personal experience, the experience of your families, are leading to poor care. And you talked about the idea of the strong Black woman that led to some of your own poor experiences in mental health care. And I've heard other Black women talk about how that exact stereotype led to their pain in childbirth not being taken seriously. I saw in the chat people were asking about the training itself and how the training that you're involved with specifically challenges or undoes those stereotypes. And I'm wondering if you could just say a bit more about that. Oh, I can't hear you. You're on mute.
Can you hear me? Yeah.
Yes, perfect.
Okay, brilliant. So it was really just opening up the conversation with the students about when somebody presents to you, not assuming that this is what a mental health patient looks like, or this is what a person in distress looks like, actually taking, because there's so many times I've been said, you dress so well, you look so put together, are you sure you've got this disorder? And it's like, don't dismiss what I'm dealing with just because I don't present in a certain way. You are not in my mind. And so really just challenging that perception, challenging on who they're expecting to be mentally ill. And I think even within our government services as well, there is for you to receive a certain amount of care or treatment, there is a certain threshold you need to meet, a point-based system to say you are ill enough in our eyes, and not really taking in what a person and listening to that experience. So really just understanding the person's experience. And that's why I say a person-centered approach is so important, instead of thinking or assuming this is what a mentally ill Black person is going to come across as or look like. They're going to be loud, they're going to be aggressive, they're going to be demanding. But challenging those stereotypes is really important. And also not expecting people to, some people don't like eye contact, some people don't like shaking hands. So we was working with a few Black Muslim women as well, and they were saying that they didn't want to be touched by a doctor. And just unpicking those sort of cultural conversations and having a safe space to really challenge those views of, well, this is what I expect somebody to do if they are normal or if they are well, and addressing that you've actually got to just listen to the person versus your own perception of a well person.
Absolutely. Thank you for that. Habib, I wanted to sort of get back to the causes of the causes. At the first day of our conference last week, Professor Sir Michael Marmot said he thought the issue of health inequity is really about health and not health care. And he says that we need to focus on the social determinants of health, the things about how we live, not necessarily through choice, that drive inequalities between different groups, so around things like wealth and income and housing and education. And I suppose my question to you is sort of how you assess the sort of relative importance of these things. I mean, do you agree that this is really just about health and about the causes of the causes? Or do you think that we also simultaneously have to be addressing the sort of the three things that you've also outlined around access to healthcare and experiences of healthcare? You know, where should we focus our attention in this space, do you think?
So the first thing to say, Rebecca, is that race inequality is a global phenomenon. It's a global system-wide, when I say system, I mean kind of society-wide issue that requires a global and society-wide response. We cannot look at, racism within healthcare without looking at the other determinants of life, not just health, of life. And so Michael Marmot, who's also a board member of the Race and Health Observatory, is absolutely right. We need to look at the other determinants, because when we look at the outcomes in relation to health, wealth, housing, education, policing, employment, the list goes on, you will find that stratification, that difference in outcomes, in access across all of those. And what we need to look at is the ability to have that discussion, that honest, what I often call being comfortable with the uncomfortable. Why is it that society is designed perfectly to give us exactly what we've got? And that hasn't just been developed over years or decades, but centuries. And in order to transform that, just as Halima said, it's not going to take 1 month or 4 years or 5 years. It's going to take time, but we need to be on the right road to have those difficult conversations in order to have a more equitable and inclusive society. And that's not just focusing on health, but that's focusing on all the other aspects I've highlighted.
Thank you for that. Halima, there's been some pushback on these issues. I actually even heard a government-appointed expert say that they didn't think there's actually a race problem in health at all, and that the unequal outcomes around COVID, for example, are actually just a reflection of socioeconomic inequality. The things that Habib's mentioned, occupational exposure, population density, multi-generational households, that those are the disparities that are driving the differences between racial groups in terms of COVID survival, for example. And I'm curious to know, how would you respond to that?
Thanks, Rebecca. So that quote that you mentioned, it came from the government-appointed advisor to look at the disparities in COVID within our ethnic minority community. So that was way back in October, if I remember. And his first kind of point of action was to deny race had a factor in the vulnerability of ethnic minority communities. So there was definitely a trust issue immediately apparent in terms of government's response and where the community was at the coalface of being affected for a number of reasons. We would disagree with that, and we would also say that we've always known that those who are overexposed to the virus of whatever ethnicity are likely to be contagious earlier than others. We've always known that. That could also be white working class communities who are living in overcrowded housing. But particular communities also live in overcrowded multi-generational households and so on. But what I would like to go back to is that statistic that I shared about the 60 of the first 100 NHS staff members to be affected and died from COVID were Black. Now, they were not economically unequal. These were middle-class Black doctors, Black clinicians. They were not suffering from disadvantage. So we go back to that point that race and socioeconomic inequalities do matter. And the reason why race matters was that those Black clinicians and NHS staff felt underprotected to exercise their right and their voice to when they felt that vulnerability. In plain English, it means that their voice wasn't listened to in the same way. Same way that Sanisha talked about, when I go in to access health, I'm not sure I'm listened to. I'm pretty sure there's a whole load of other assumptions that are overlaid on my experience before I've even spoken. That's also the same with middle class staff who actually work in the NHS. So he was wrong, but thankfully, if you recall, in the last month or so, the government itself has acknowledged that race, ethnicity, and socioeconomics is a major risk factor in COVID as well. So we have been lobbying and lobbying for ethnicity and race to be recognized alongside class and other inequalities. So we're not denying the existence of socioeconomic determinants. We agree that's a factor. What we would add in the mix is the toxicity of racism as well, which so far government has failed to acknowledge. But due credit, a month ago, they did say, do you know what? There might be a reason why minority communities are not accessing the vaccine. And it's not because they tend to ask 100 additional questions. It may be because they've accessed unequal health outcomes over the years. So their trust levels in the NHS is a lot lower. So even government has, I think, come round to our view from where the scientific advisors were about 6 months ago.
That's great. A question that I want to put to all of you, and that I can see coming up all over the place in the Q&A and in the chat, is around action. I mean, I think there is this, this tension where on the one hand, as Habib just said, we've got centuries, decades of institutional, structural racism, legacies of colonialism, slavery, all of this to contend with. And on the other hand, there are maybe many people in our audience here today who really want to do something about this, but they may be not charities that are focused on health, or even if they are within the health sphere, they're focused on a range of different health inequities and a range of different health issues, let's say, beyond health inequities. And I think what would be really useful, I think what people are really asking for here is a sort of steer as to something they could do in very pragmatic terms to try to bridge between these things, bridge between the enormity of the problem and their limited capacity, resources, the things that have come up in barriers in that word cloud, to really try to make a positive, sustainable difference. So I would like to know from each of you is what is the sort of one action you would ask people here today to take away, to do, either today, tomorrow, in the next month, the next year, you choose. And I'm going to come to Sanisha first, if that's okay.
Yes, so I think the key thing is collaboration, and collaborating with, if you have little financial resource to run huge research projects, or reach out to communities with vast marketing projects, etc. I think collaborating with local communities and other charities within, or third sector organizations within your local community can really help bridge the gap and open up your engagement with diverse communities. So I think it's about not necessarily seeing the barriers. We don't have the people here, but the people are on our doorstep, and how we're not meeting this community, going out to the community and actually letting them know about your services, rebuilding that trust, going to local organizations that do work with these communities and saying, what can we do to really open the doors so we can work together? I think collaboration is, there's a lot of gatekeeping within the third sector, and that needs to change.
Absolutely. So go out to communities, ask them, listen to them, respond to that.
Yes, community groups in particular. There's so many small localized minoritized community groups, and I think if there was less ring fencing, less gatekeeping of these are our people, let's work together, how can we build trust, and actually being intentional with that is the key point, and not just a one tick box sort of, we've invited them for this 1 year, this one moment in Black History Month or Asian Heritage Month, but actually throughout the years, building a 5-year-long plan. How are we going to engage this community? What are we going to do to build on what we've wanted for so long? Because the thing is, these statistics have been here and will continue to be here because the action is not being done. It's constantly the barrier of there's these people, but I can't access them. I can't access them. They're there. Access them. Access them. That's what needs to be done.
I think that's absolutely right. And one thing that sticks in my mind from talking about health inequalities in general as an organisation over the last year is that communities and people are not hard to reach, they are easy to ignore. And I think that's such an important thing to remember. Thank you, Sanisha. Habib, what would your sort of one action be that you would implore people to take on hearing this?
Well, I would turn that around, Rebecca, and I would say I totally agree with that. But the statistics that we see, the disparities that we see, should not be the burden of those that are most affected by them. So I turn it around and I said, actually, it's not just a responsibility of local community groups, but it's a responsibility of those national organizations that are not reaching out as well as they should be to those local community groups. And so, you know, we need to ensure that inequalities are addressed, not just by words, but by deeds and by actions. And national organizations need to be doing more to focus on that level of engagement and to make sure that they're actually engaging in a sustained and meaningful way. And so it's not, you know, when the person at local level burns out or the money runs out and that's the end of the program. There needs to be sustainability and meaningfulness in that level of engagement. So I would say, yes, absolutely, we need to do stuff at local level, but there's a responsibility here, a much bigger one, I say, for those national organizations that should be engaging more and providing more resources.
Absolutely, and not pushing back the work, exactly as you say, onto people who themselves are struggling and dealing with the impact of all of the structural racism. But I think just thinking about the audience here today in terms of voluntary sector organisations in large part and what they can do, so then would it be that what you're saying is them asking those national organisations to be doing this work and engaging with local communities and doing it?
Well, not just asking, but actually telling them. Actually, there needs to be that level of accountability for those national organisations on this agenda.
And just one thing that relates to that people might be interested in is the Inequalities in Health Alliance run out of the Royal College of Physicians. People might want to reach out to them because they have in fact been calling also on the government to introduce a socioeconomic protected characteristic into the Equality Act and calling for a cross government strategy on health inequity. So that might be something the voluntary sector organisations here today might want to be involved in. Halima, turning to you, what's your response to this question about action?
So I would just go straight to the outcomes we want to change, right? So in my local area or in my national area or in my local primary healthcare trust, if the outcomes for particular groups are poorer, I'd want to commit to changing those outcomes. And that would then bring in a whole host of interventions that are required to change that outcome. So for example, if you look in the field of gender equity, for example, in the last 20 years, many of us who've worked in gender know that we had to commit to changing those outcomes, whether that was in the boardroom, whether that was in the primary healthcare trust, whether that was in an NHS ward in East London. You have to look at the outcomes and say, that's pretty unacceptable. What are the interventions that are needed to change that? So start with the outcomes and the results and say it's going to take 5 years or 10 years or 3 years. But if you don't start with the outcomes, our impact and ability to influence is always going to go back to those who actually are bearing a hit hardest, but don't have broad shoulders, so to speak. So you have to go to the outcomes. I think you can take the action at the local level and the national level. So, you know, the head of the NHS would have a different set of actions compared to the primary care trust in Tower Hamlets where I live. So if you start with the outcomes, you might get a more systemic result after 5 years.
And that is a fantastic note to end on, I think, pulling it all together from working back from outcomes to dealing with the here and now and from thinking about this on both national and local levels. Thank you for that, Halima. We've got a couple of minutes left, so I'm going to wrap up now. And just to say, I mean, many of us, I'm sure, if not all of us knew before this talk, but probably realise even more now, you know, it's not easy. Tackling racism in health and healthcare is neither simple nor easy. And obviously we can't solve all of this in 60 minutes. But I hope you agree with me that the speakers this morning have not only deepened our understanding of the range of issues, but also very helpfully highlighted some possible entry points that each of us in our roles and organisations could take. And shown us what could actually be achieved when we work together. Thank you so much for joining us this morning, for sharing your reflections and questions. Thanks to our 3 fantastic speakers for sharing their experiences and their insights. Thanks to the teams at National Voices and PPL for putting together this all singing, all dancing webinar. And thanks to our sponsor, the Health Foundation. For more on what is happening in the voluntary sector to combat these racial inequalities, please join us this afternoon. We have 2 sessions that are organised by our members, but they're open to you all. I'm using the same Zoom link as this morning's session. You can see at 1 p.m, we have the Resuscitation Council. They'll be leading a discussion about partnership working. And at 2:15, we have Birthright and Youth Access. They'll be leading a discussion about how to address racial injustice in maternity care and in young people's mental health. I hope to see you there this afternoon or this time next week when we're going to be discussing digital exclusion, or the following week, the 23rd of March, when we will close our conference with an extended plenary discussion about what next, how can we take action together. So see you then, I hope, and thank you again for joining us this morning. Have a great rest of your day. Bye-bye.
Thanks, everyone.